welcome everyone to The Nutshell, and we're pleased to say that today we are speaking with board-certified hematologist-oncologist Dr. Urvi Shah. Now, Urvi works as part of a multidisciplinary team at the Memorial Sloan Kettering Cancer Center in Manhattan in New York. So welcome, Urvi. We know you're a hematologist and oncologist, but can you tell listeners a bit about yourself and how you came to specialising in this area?
Thanks so much for this invitation, Claire and Daisy. I was diagnosed with Hodgkin's lymphoma in 2016. And that experience where I went through treatment and had friends and family telling me, maybe you should eat this for good health, or this may benefit you, this supplement. And me realizing that as oncologists or even physicians, we don't really get a lot of training in this. And so after I finished treatment, I started reading quite a bit about nutrition and lifestyle changes in cancer. And I realized there's quite a bit of evidence, but we don't really share that with patients as much as we should. And also there aren't as many good randomized trials done in oncology like there are in cardiology or other diseases where there are dietary and lifestyle studies being done. And so it piqued my interest, and I thought of it more as a side hobby because I was still continuing to do mainstream research like genetics and immune therapies. But it was always at the back of my mind that I wish I could do something in this area, maybe a pilot study, because I was very fascinated by it. And so when I started at Memorial Sloan Kettering in 2019 as faculty on the myeloma service, I spoke to my chief and I said, would it be okay if I do one study where we look at how diet affects the disease in patients with the precancer or precursor state as a pilot study? And he was very supportive, which was great. And then that one study led to me, building on it. And then it became the full career. And I stopped doing as much of the other drug-related research. I still do some of it, but I think it's shifted more towards lifestyle and dietary patterns. And it's been really rewarding to be able to do something that I found was also a passion of mine, as well as bringing it to research and part of my job as well.
Well, there's nothing like finding yourself as a patient to get you really interested in the subject, is there?
Yeah.
But we know that you're a blood cancer doctor, and a lot of the people listening, they'll know some big titles of blood cancers like leukemia probably and lymphoma, but there's a broad spectrum, isn't there? So which particular blood cancers do you specialise in? And can you tell us more about what these diseases are?
The general population has commonly heard of leukemia and lymphoma, but myeloma is not one that most people have heard about. Although it is the second most common blood cancer when we think about the numbers, but it affects older people, usually in the age of 60s. And the reason modifiable risk factors are relevant to multiple myeloma is one of the early pieces of evidence when the research done into which cancers have sufficient evidence for obesity and the link to cancer, multiple myeloma features within one of those 13 cancers. So it is the only blood cancer where there's a clear link with obesity compared to leukemia and lymphoma, where there are some studies, but it's not enough data or evidence to more convincingly say it.
How common is multiple myeloma?
So it's not that common. I would say in the United States, every year there are about 35,000 new diagnoses per year. So that's considered a rare disease. But the precancerous or precursor states to multiple myeloma, which are called monoclonal gammopathy of undetermined significance. I know it's a mouthful, but you can just use the term MGUS or MGUS, and smoldering myeloma. These are considered precursor states to myeloma, similar to how in breast cancer everybody's heard of DCIS, which is considered the precursor state to breast cancer. And that gives us an opportunity to actually study prevention to cancer when somebody has a precancerous state already. And we also know that in these precancerous states like MGUS, if you tested the whole population over the age of 50, at least 3% would have this protein. So it's not that rare when we test everybody. It's just that not so many with the precancer will convert to myeloma in their lifetime. And so the cancer is rare. We do know that these precancer states are associated with risk of progression, and there are some modifiable risk factors that can affect risk of progression. And one of the clear ones before I started doing the research in this area was obesity, where there were three studies that showed that people who had a BMI over 25 with this disorder were twice as likely to progress to myeloma than if they had a normal BMI. So, already suggesting that maybe if we could help those patients with the precancer state achieve a normal body composition and weight, maybe we could delay progression. So, that was some of the preliminary data and background for the trial, the pilot NUTRIVENTION study that we set up.
And you mentioned this MGUS. You mentioned that's as common as up to 3% of the population over the age of 50. So you've got that group. So do you think any of this feeds into who actually becomes in the preliminary risk? So who gets that precursor condition? Anything that we know about lifestyle?
Yes. So we did a study looking at dietary patterns and MGUS risk, and we saw that sugar sweetened beverages, whether artificially or naturally sweetened, were associated with about a 40 to 60% increased risk of MGUS, and whole grains, cruciferous vegetables, fruits were associated with about a similar 30 to 70% reduction in risk of MGUS. And this was based on, again, an epidemiologic large population study with case control through the NHANES that we conducted, looking at risk of MGUS with dietary risk factors, so before they develop MGUS. Of course, MGUS is not all about lifestyle, right? Myeloma and MGUS is a disease that's seen as we age, it's more likely. So with each decade, the percentage of people getting MGUS increases. So that's one common risk factor. Race is another big risk factor. So Black are twice as likely than white to get myeloma. So there is some genetics at play there too. Environmental risk factors like carcinogens also play a risk factor. So Agent Orange, 9/11, dust from the World Trade Center. So firefighters who are exposed to it have an increased risk. So there are factors that are also not controllable by patients. And so when with cancer, precancer states, if somebody's diagnosed, it's not only because of lifestyle factors, but we like to focus on lifestyle because that's the only thing that's truly modifiable in terms of what we can do to help or reduce our risk going forward.
So what we seem to be saying is that in the same way that we know lots about reducing particular, say, gastrointestinal cancers, like we seem to know a lot about colorectal cancer because it's quite common, those same patterns of carcinogens are borne out for hematological, i.e. blood cancers. Is that about right?
That's about right. I think that for hematologic cancers, the epidemiologic data is not as much as for colon cancer. And the reason is these are rarer cancers. So, for large studies, to have enough patients that you can actually statistically prove some things or look clinically meaningful outcomes, you need enough time and enough events to happen. So some of the databases did not have enough of that for somebody to study it earlier on. And now more data is coming out. But also they are rarer cancers. So there are fewer databases that would have that kind of data. And so, yes, it is a bit more challenging to study it in a rare cancer compared to common cancers. But I think the same themes apply. Maybe certain cancers they apply more or less, like obesity may be more of a driver for myeloma than leukemia or lymphoma, or diet may play more of a role or benefit in some cancers versus the other, maybe GI cancers compared to the others. But I think overall, there are similar patterns being seen throughout. It's just what is more or less at play.
Are we at the point of knowing what the actual mechanisms are by which diet as a risk factor can make a difference to your chances of developing a cancer?
We do know quite a few. There's a review article we put together in JAMA Oncology a few years ago, trying to look at mechanisms between how diet affects cancer risk. And we focused on plant based diets and ketogenic diets, just given their opposing patterns. And there's a lot of attention given to ketogenic diets in cancer. So we felt like we want to really talk about why and what the mechanisms may be. What we do find with plant based diets is that the high fiber foods, I joke, but I think it's kind of fiber is like an immune therapy or the original immune therapy compared to all the new ones we talk about. And so the dietary fiber affects the gut microbiome positively. Things that we would expect would be things like an increase or a change in gut microbiome diversity with fiber rich foods, change in the types of bacteria and species. So things like butyrate producers or healthier or more beneficial bacteria. And when there's a change in or a shift in the microbiome, there's a shift in short chain fatty acids and other metabolites made by the microbiome. So that as well. So that would be one mechanism, and how that modulates the immune system and inflammation. And then I'd say another mechanism you could think about is how diet affects insulin resistance and weight, and that affects cancer risk, because we know that higher insulin doses or higher insulin levels actually associate with increased cancer risk. And there's a nice study in JAMA Oncology where they looked at type 1 diabetics and dose of insulin, and they showed that there was a dose dependent effect on risk of cancer from just the amount of insulin somebody needs, because insulin probably is driving growth of the tumor. Possibly they didn't show mechanisms, but I think dose can make a difference. And so if somebody has diabetes and needs insulin, yes, it's important, but maybe a lifestyle change can reduce the dose that's necessary. So overall, I think those would be two main mechanisms, or you could also think about it as microbiome, metabolic changes through body composition, weight, insulin resistance, and then immune changes like reduction in inflammation and changes in anti-tumor immunity, like different immune subsets changing. So I would think these are all the mechanisms that we know so far, but I'm sure there are many more metabolites, and this is just a very simplified version.
Right. But anyway, it's easy to remember because it cuts across so many other areas in terms of development of diseases, doesn't it? That we know the microbiome is important, we know fibre is important, and we know that production of short chain fatty acids is really important. We know you've been looking specifically at plant-based diets compared to other dietary approaches such as the keto diet, but what exactly, if you had to describe it to the patient that you were proposing it to, what exactly is the diet that you are working with in your research?
So we help patients for 12 weeks try to focus and stay on as much of a high fiber plant-based diet as they can. We're aiming for 100%, of course, for the patients to do it for 12 weeks, but we want to meet patients where they are, and we want them to let us know honestly what's feasible for them and how they can do it. We also provide food for 12 weeks where we send them lunch and dinner, not all the calories, but part of them, because we send lunch and dinner, but not snacks, not breakfast. And we do this because if you're expecting somebody to suddenly make dietary changes, especially in a trial where we want to see biomarker and clinical endpoint changes, it can be overwhelming or challenging for somebody to suddenly make the change, and they may need more help along the way. But when we provide the food, all that they need to do is heat it up and eat it, and then maybe supplement it with snacks, soup, salads, other things that they may want, or breakfast items which we guide them on. And so it takes away a bit of the burden of trying to learn new recipes and cook immediately right out of the gate. but we do teach them that and help guide them with sharing recipes so that they can use this for more long-term change. And what I find for the majority of patients is that once they've done it for a few months or even a month, they find that they feel better. And once they feel better, then that motivates them to continue. And we have patients doing it very much long term beyond the time where we provide food to. So we do 12 weeks where we provide the food, and then for 24 weeks we provide coaching, and then we just follow them long term on that pilot study to see are they still doing this like a year later. And surprisingly, we saw very high adherence or compliance even long term, with many patients still continuing to do a lot of the changes we discussed. So when we calculated, for instance, unprocessed plant food intake in terms of total calories, at baseline, their diet was close to a Western diet, maybe slightly better, but at 20% of their calories were unprocessed plant foods. Everything else was either processed or animal foods. And then on the intervention, while we're providing food, it was close to or 90, about 90%, 92%. When we stopped the intervention and 1 year later, it was around 60%. So it's maybe not as high as on the intervention, but much better than where they started at 20%, showing that many of them have found changes that benefit them, and then they can add back things maybe in a more conscious way of what they feel like they're really missing or want to change or add back. But otherwise, they've got the basics of what they can continue long term, and they know what's most important to them.
Right. So the NUTRIVENTION study, is that what you're talking about now with the 12 weeks?
Yes. This was a very small pilot. It was only 20 patients with a BMI over 25 and patients who had these precancer states of MGUS or smoldering myeloma. We wanted to see feasibility, which we achieved. The patients lost about 7% of weight at the end of 12 weeks, but even this was maintained 1 year later. Quality of life improved. Microbiome improved. So microbiome diversity, probably many listeners have heard of this concept, but many others it may be a new concept. And when we think about microbiome diversity, think about it as a rainforest compared to a plantation. And I think that a rainforest is just a much healthier ecosystem and environment. And that's the same with our microbiome, where we want the diversity for the most part. And most studies in oncology or cancer have shown higher diversity associated with better survival. And so if we can modify diversity, could that affect outcomes? In our study, we were able to show that these patients actually had improvement in their gut microbiome diversity by 12 weeks, and even 1 year later, their diversity was higher than baseline. We saw a shift in bacteria as well towards more butyrate producing bacteria. We also looked at insulin resistance, and while they didn't change their carbohydrate intake, they reduced refined carbohydrates and increased fiber intake. And you could see a drop in insulin, a drop in hemoglobin A1C. There was one patient on insulin for 30 years who was able to stop during the study as well. And then we looked at things like inflammation and other immune changes. We did see C-reactive protein levels drop by about half in the 7 patients that it was elevated. We also saw improvement in LDL cholesterol. And then immune system, we saw shifts and the changes in the interaction of the immune cells. So there are many different subsets that we saw shifted, and I won't go into the details of it. But what we're seeing is that the immune system is moving towards a more quieter, less inflammatory kind of immune system. And we did this through even bone marrow single cell RNA sequencing of paired samples. So probably the only dietary study that's been able to look at how the bone marrow immune changes also take place with a diet. The clinical endpoint of could it change progression or disease trajectory? It's a very hard thing to study because MGUS and smoldering myeloma can take decades to progress for some people. In others, it could be a shorter time. We enrolled a very heterogeneous population, some with low risk disease that may not be progressing, others who had clearly rising numbers that were progressing over the course of a year or two. What we did see is that two patients whose numbers were clearly rising before going on the intervention had a slowing of their numbers compared to before. There's a slowing of the progression for those two patients. So while it's only two patients and it's a hard endpoint to study in a short period of a trial, we may see a signal that may suggest that this could delay progression if a patient's able to long-term make changes.
We're constantly hearing that with randomized controlled trials where you're involving diet, it's impossible or it's difficult to control what people are eating. And what I was interested in is how your study identifies people who are going to be good candidates for controlling their diet, either in terms of sticking to a diet that you know to be most likely to be the healthy one versus continuing how to eat how they were before when they have been told that they've got the risk of cancer or they've got cancer. And I guess in that second part of the question, what I'm interested in is how close you might be to having to stop a trial, because if you think about a drug, if it was coming out clearly that one arm was benefiting significantly, it would be unethical to be putting people in the other arm. So what does that look like for a diet study that's randomized control?
It's a great question. I think in cancer, we don't have too many randomized trials that have had positive clinical endpoint results yet. There are a few trials, such as in breast cancer, but many other trials have not been powered to a primary endpoint of a clinical endpoint of response or survival. And some of the very large phase 3 trials that have been done that were negative were looking at things like low fat diets or and a long term endpoint of survival for many years. There are a few challenges inherently with doing a dietary study. One is that it's not like a drug that's on or off, right? If the control group doesn't get the drug, it's zero, and the group that gets the drug, it's almost like 100%. So there's a great difference between the two groups. When we do a diet, it's not like one group is not eating or just eating completely a different diet. There is going to be similar foods being eaten by both groups. It's just the amount or the quantity that changes or the pattern. Of course, there's a bias for people who go on to dietary trials where they might be interested in this question and they think like, oh, maybe they're studying this, so maybe that's good for me. And then even the control arm may start changing things for their diet. So that's like the drop-in effect of the control trying to do what the intervention's supposed to do. And then the issue of the intervention, because it's a behavioral change, they may not do it 100%, they may do it 80% or 90%. So we basically have a little bit of reduction in that difference that we're trying to see. Another issue is cost, like doing studies that are extremely well powered, that have enough patients, and we're able to provide coaching to a huge number of patients. It is very challenging and requires a lot of resources and planning. And so some of these issues come into why I think randomized studies are hard, but that doesn't mean we shouldn't do them. And we have some randomized studies ongoing, and hopefully we'll have some interesting results to share.
Obviously, when people find themselves diagnosed with something, they are quite motivated. They're willing to try an approach that shows promise. Are they competing with other ideas in terms of what other researchers are doing? What other diets are showing promise in reducing myeloma risk?
I don't think there are any other studies being done with dietary interventional trials in myeloma so far that I'm aware of. We have about 5 different trials going on in myeloma. 4 are ongoing. 1 is going to start later this year. And then we're also going to be opening a study in clonal hematopoiesis, which is pre-leukemia. So we have totally 6 studies that are either ongoing or completed or going to start. After the pilot NUTRIVENTION, we have NUTRIVENTION 3 that's in the same population of MGUS and smoldering that's currently enrolling. But we have 3 arms in that study. One group gets diet, one group gets supplements, which is curcumin and omega 3, and the third group gets placebo supplements. And the supplement and placebo supplement groups are double blinded, so they don't know which one they're getting. And we allow a crossover for the supplement groups after 12 weeks to get diet, so everybody gets diet. But that allows us to have a design where in the first 12 weeks, everybody is either blinded or feels like they're getting something, and it may lead to less of somebody wanting to change their diet potentially. But we have not yet analyzed the results. The study is large, 150 patients. So hopefully in the next few years, we'll have some results. And then we're going to be doing another randomized study in the newly diagnosed population, where these are patients with newly diagnosed myeloma, where half of them would get a dietary intervention and half would get their standard chemotherapy without the dietary intervention. So both groups will get their chemotherapy, but one group gets diet with the chemotherapy, the other one just gets the chemotherapy, which is what is the current standard.
Urvi, I think you've described the challenges of nutritional studies really well there. Having seen the benefits in your research on plant-based diets, do you now talk to patients about that as a practicing clinician? And, patients often ask us, well, how plant-based do we actually need to be to get those benefits?
Yeah, it's a good question. I do share the results from our studies and other epidemiologic studies. I have ended up giving a lot of presentations or talks to patient foundations on these topics, and many of them have uploaded these talks to YouTube. So often patients do listen to them or hear about it and decide on their own based on the current level of evidence that they want to make changes. I think in as physicians, we are trained to think that the only time to start making a change is once we have a phase 3 randomized control trial proving a benefit of something. And that's true for drugs. I think if we wait for dietary studies for every disorder and disease and stage and time to happen for all cancers and all disorders, I don't think that will ever happen, because the just the cost of doing such studies, the funding for it, there is no pharmaceutical company that's funding these kind of studies, and they're very time consuming and intensive to do. So I think we have to take the evidence we have and think about what works best for us at that period of our time and try to apply some of it. It does help when you have a disease where an investigator has done a few studies, maybe in similar populations, because then it helps the patients understand, like, okay, similar patients have seen benefits, so maybe this is something for me. And I think that's what I have noticed and we're seeing in the myeloma community. Because of these trials, many patients are now thinking about increasing their fiber intake or making changes across the globe outside of just our studies.
Yeah, and I think patients feel empowered when they know they can make changes to their lifestyle that can make a difference. And I think, when I speak to patients, they certainly want to be able to take control and make some changes. But I find actually speaking to my colleagues perhaps a bit more challenging. How have your colleagues in hematology or oncology felt about the results that you're seeing?
It's been mostly positive. I would say there are differences of opinion where some people feel like it doesn't make a difference or it doesn't matter and we shouldn't be pushing this on our patients. And I would say the other side of it is there are many who are very supportive and very excited about this research because patients really want it. And this is truly a very unmet need, because it's probably the most commonly asked question, especially in cancer, and the least likely answered question by doctors. And so I think it is addressing something that patients really want. But it's also leaving the choice up to the patient. Like even in my clinic, it's not that I'm telling every patient this is what you have to do, but just sharing the evidence, and then they decide whether it's worth it for them to make those changes at that time. But once there is evidence, it feels more compelling to make changes, or there's more reason why they might think about it or want to do it. So I think it has to be a bit personalized and meet patients where they are. Sometimes when a patient starts treatment or they have a relapse, they might be a bit more overwhelmed with the drug related side and the medical side. And I think in that situation, to try to change everything can be more overwhelming than beneficial, maybe. So we have to tailor it to each patient. And that's what I do in clinic too, where if I think a patient may benefit, I might mention it to the patient, but I also want to see if the patient is interested in or receptive to hearing about it. And if they feel open and receptive to it, then I might add a little more or discuss it. But if they don't are not receptive, I'm not going to push them to do something where they don't feel ready to. And I think the other thing that I often do in clinics, because clinic time is very limited with each patient as doctors, is I will just say a sentence or two. I think a patient hearing from their doctor who says, yes, it matters, it's good you're making these changes, makes a big difference and goes a long way. Because many times, if doctors dismiss it and say, oh, it doesn't make a difference, do what you want, it makes patients feel like the doctor doesn't fully understand what's going on, and it creates a divide between the patient and the alternative side and the mainstream. But if doctors can just actually acknowledge if a patient bringing up these things, I think it can go a long way. And if we can just share resources, so I often will share links to things that I think could be good, videos for them to watch some of the talks I may have given, or links to recipes or a website that I think might be right for them. And so we don't need to spend too much time in the clinic. It's just a couple minutes and then send the link later. But that is enough to help them start thinking about it. If they are truly motivated, they will open that link and read more. And then I say, next time I see you, we can chat more if you have questions after you look at that.
Yeah, absolutely. I tend to send the link to the World Cancer Research Fund where, nutrition guidelines is completely embedded in there. And I often think, seeing that, I do still wonder where the resistance is, given that nutrition is already embedded in these guidelines. I don't know if you've got any thoughts on where the resistance in our colleagues comes from.
I think a couple of things. One is that oncology is only recently in the last 10 years really changed. Before that, we had chemotherapy that would cause GI issues. Survival was not that great with cancer, and weight loss was a major issue. Now we're moving into a space where not all treatments have GI issues like nausea, vomiting, diarrhea. There are a lot of patients who actually have metabolic disorders along with their cancer, and they're not having the weight loss as the issue, but they might be gaining weight on treatment with steroids or other things. So I think there's a shift. Plus, we now are using more immune therapies, and I think immune therapies, there's some data of how dietary fiber with checkpoint inhibitors may actually have a synergistic or beneficial effect too. So, with immune therapies, there may be more of a reason why mechanistically that we should be thinking about it. And then lastly, I think microbiome has come more to the forefront in terms of our understanding of it. And we know diet's the biggest driver or a modifier of the microbiome. So I think all of these things have shifted the way we should be thinking about it in cancer. And the challenge of why oncologists are still skeptical, part of it is because of the data or how patients used to do before, and feel like they need to tell patients, it doesn't matter, we just don't want you to lose weight, eat whatever you want. And the other thing is that most of the World Cancer Research Fund guidelines or the data that they use, they base it off is based on epidemiologic studies or population based studies, but not interventional randomized clinical trials. And as oncologists, more than any other specialist, we're trained to look at interventional drug trial research because oncology is fast moving in terms of the number of drug approvals or changes in treatment. And most doctors who practice oncology have to keep reading new trials and drugs related research. So they're looking at it with that lens and saying, we don't have the trial kind of data. So how do we say it compared to if we just have epidemiologic data? But I think that's changing. We're now seeing with exercise in the colorectal cancer, the challenge trial, which was a phase 3 randomized study that was positive. And so I think hopefully over the next 5-10 years, now that patients are living longer, better, and we can actually do these modifiable trials, that we'll probably start seeing better data that convinces more oncologists.
That makes complete sense. Yeah. And where do you hope that the lifestyle oncology field will be in 5 years?
Ideally, as much as we're talking about drugs, we should be having programs in each hospital that patients can actually take part in to make these changes. So we are not only just telling them you should do this or you should make the changes, but we have programs integrated into the healthcare system that could make it easier for them to do, that's reimbursed by insurances. And I think more oncologists just starting to talk about this with patients, just saying it matters with their patients.
Yeah, absolutely. Because like you said earlier, if people make those changes and they feel better, they see, LDL come down, like you said, HbA1c come down, all these things can actually really motivate people to continue, can't it? And what about myths when it comes to lifestyle and cancer? Is anything that you would love to just debunk once and for all?
I'd say one of them is carbohydrates or sugar feeding cancer. And that's where very commonly comes up, where people think that once they have had a diagnosis of cancer, they can't eat carbohydrates. But I think it's very important for people to understand that carbohydrates, proteins, and fat are three building blocks of most foods, and they're going to be there in most foods. But the question is what kind of carbohydrate they're focusing on. So, refined versus complex make a very big difference, and they're very different carbohydrates. So, while every dietary pattern that's healthy agrees on cutting down refined carbohydrates, some like low carb or ketogenic diets may say also avoid complex carbohydrates, but with that we are avoiding dietary fiber, which is an important aspect of a healthy diet. And so I think it's very important that patients understand that whole grains are not bad for cancer. They actually may help. There are studies showing actually increased consumption of whole grains with reduced cancer risk or better survival, just because of the fiber that comes through these foods, and also flavonoids, vitamins, other things. So I'd say that's one very big one. And then I think another one is protein and cancer, where when a patient gets diagnosed, the doctors and also the patient will feel like, oh, I have to eat more protein, because part of it is because the thought is that they may lose muscle and develop cachexia or wasting, and so they need to eat more protein. But I think even that needs to be looked at in an individualized manner and thought about, because very high protein diets without actually making exercise changes aren't really going to make a clear benefit to the patient. But it's more important that they actually, with the changes in the diet, also do the physical activity to build the muscle. Otherwise, just high protein without exercise to build muscle doesn't build muscle alone. Is only important maybe in some situations where a patient just has cachexia or wasting and really not able to eat, where we have to think about increasing calories of all kinds, including protein. But other patients, I think it's more important that they focus on fiber intake as well as exercise too.
Great. Well, we got two myths busted there. And I don't know about you, Daisy, but I thought it was much like listening to even colleagues when they find out that they're pre-diabetic or they've got diabetes, and they start talking about, I've cut out right down on carbs. And I think, oh no, but which carbs? And it can take quite a lot of effort to get somewhere with them. We're getting on to the bit now where normally our question is exactly this: what are you having for dinner tonight? But we do allow some creative license. So if you'd like to tell us about what your favorite plant-based meal is, you can tell us about that, whether you're eating it tonight or not.
It's a great question. I'm quite a foodie. I'd say I do enjoy a lot of different foods, so it's hard for me to always pick one. But I'd say if I'm eating out a lot because of traveling, then the thing that I miss or crave the most would be a bowl of just whole grains and lentils that's warm with a lot of spices. I think that feels like a comfort food that I do enjoy. And then often adding some veggies for the crunch or maybe sauerkraut on the side. I think can be like purple cabbage or a thing that's cut up can be a nice crunch to a bowl of that.
I think we can both really relate to that sort of feeling that when you're surrounded by food that you don't really want to eat when you're on the go, the nicest thing is coming back to something really simple. I'm exactly the same. And you mentioned sauerkraut, and me and Daisy, we actually went and did a whole food medicine day recently where we made our own sauerkraut.
Oh, wow.
So I don't know whether Daisy's having that for dinner tonight.
I'm not. Are you having that for your dinner, Claire?
I think I might have got one of the steps wrong.
Oh dear. I won't ask.
Yeah, I'm still wondering whether to come back to it, but we'll see. No, what are you having for dinner tonight, Daisy?
It was like Urvi said, so I am actually traveling at the moment, and I have finally found somewhere where I can get a Buddha bowl, like a poke bowl. So it's just pretty simple rice, tofu, but lots of different veggies on the side. They've got like these beautiful carrots that they've made into like a ribbon, and there's a bit of sauerkraut or kimchi type thing, and some avocado on it. It's just beautiful. It's like lots of different veggies. And I've had that 3 days in a row since I've been here. Yeah.
It sounds like a bowl with a lot of variety too, like many plants in one bowl. So
that's
awesome.
right. Exactly. So I'm going to have that again tonight. And that will be the last time. I think 4 days in a row is enough. How about you, Claire?
Well, I was thinking about this. I think I know what I'm going to have tonight, but I thought I might amuse you with what I had last night when I got in late from work. I opened a can of baked beans, which is obviously, a slightly processed food there. And I had some wholemeal toast, and just to give myself a protein boost to those already protein full beans, I took a handful. I don't know if this is even allowed. I took a handful of dried soya mince and I mixed it in and I put it on the toast.
It's actually a genius idea. Was it good?
I loved it. And then I put some yeast flakes on top. So, it was some of the good stuff, some of the less so good stuff, but I really, really enjoyed it. I mean, you could improve on it. There are ways of making your own baked beans from haricot beans and making your own tomato sauce and stuff. But as a kind of, I'm tired, I'm home from work later than I want to be, that's what I had.
Yeah, you're going back to your student days.
Pretty much. But, dinner on your own, baked beans on toast, you can't beat it really. So that was comforting. But tonight I've seen a recipe for garlic butter tofu, and it is just, it's tofu that's marinated in a sort of garlic and a bit of oil and garlic powder and some onion powder and some paprika, and a slice of that. And then I'll have that with more healthy things, so probably some steamed broccoli and some new potatoes.
Sounds really good.
A microbiome will be happy, Claire.
Well, I hope so. That's all I need to keep happy. Anyway, thank you so much for joining us, Urvi. And I think that it's particularly been heartening to hear about research that is really, as you've identified, it's getting in there. It's not talking about drugs. It's talking about things that we've all got access to. So those lifestyle measures, whether it's diet or exercise. So yeah, the more we can find out about food as a drug and something that doesn't have those side effects that some of those other treatments have, I just think it's amazing what you're doing. So thanks so much for joining us.
Thanks so much, Claire and Daisy. I really enjoyed chatting with you both. And it's amazing that you're spreading all this knowledge with your listeners. I think it's very important. So amazing work.
Thanks, Urvi. If people want to read more about what you're doing, where can they find you?
My social media handle is at Urvi Shah MD, whether on all platforms. So on LinkedIn, Twitter, Instagram, Blue Sky, and Facebook.
Fantastic. Right. Well, we'll put those links in the show notes, as well as the links to all your wonderful papers for people who really want to dig a bit deeper. And we'll see you all next time.
Thank you.
Sounds great. Take care.